What's going on, everyone? It's Alex here from Alex Physio. Today we're going to be going over a sample lumbar spine MRI report. Welcome. For those of you who are new to my channel, my name is Alexander Kravich. I'm a physiotherapist in Vancouver, British Columbia, and today we're going to be reviewing a sample MRI report of the lumbar spine for someone with low back and leg pain. This is a report that I just found on Reddit, so I don't know who the individual is or what's going on. I just looked at the report. I want to try to decipher some of the terms that are used. So if you've ever had an MRI, just to try to explain what's going on, if you ever had an MRI for a neck, low back, mid-back pain, to go over what some of these terms are and what the significance of it is, to hopefully give you a little bit more confidence in reading your MRI if maybe somebody didn't go over it with you. Okay, so let's get started. So it says history. This is just trying to find out what the history of the individual's presentation is, what they're complaining of. So it says a spasm of back muscles, lower back pain with left sciatica, lower back pain with right sciatica. The technique is just how are they getting the images and the type of MRI that they're using. Comparison, there's none, so they have no comparison to look at if the MRI report looks better, same, or worse. This is likely the individual's first MRI, at least the first MRI that they've seen within the hospital or the jurisdiction where they did the MRI. And then findings. So basically the layout of the MRI is under the findings, they comment on all of the spine and the characteristics of the spine. Sometimes they just put it as one blanket statement, just with regards to making sure everything else is ruled out, tumor, cancer, infection, any sort of lesions. But sometimes they break it down. So in this case, they actually broke it down into each individual segments or structures that they're looking at. And then below that, they have a layout of the MRI at each level. So we have 5 levels in our spine, and they make a comment at each level, and then at the bottom they put an impression or summary. So usually I would go down to the impression first to look at what the bottom line is, and then go up if I need more information. So in this case it says under the impression, lower lumbar spine degenerative change most notable for L4-5 level, moderate lateral recess narrowing with impingement of the descending L5 nerve roots. Okay, so when I look at that, it says that there is some wear and tear changes, so lumbar spine degenerative change, and then it says it's most notable at the L4-5 level, where there's moderate, so they grade how much narrowing there is in terms of qualitatively, mild, moderate, or severe. So in this case, it says there's moderate lateral recess narrowing, and the lateral recess is basically the area of the pathway where the nerves come out of once they branch off from the center of the canal and before they exit out of the tunnel. So the tunnel are the foramen, which is mentioned in another part of the report, and then the lateral recess is just before the foramen. So just saying that in that specific area, there's narrowing moderately, and there's impingement or pinching of those nerve roots before they exit out of the tunnel to go down your leg into your feet and toes. So when I look at that, I say, okay, the individual has pain, sciatica pain going down both legs, and they also have irritation of these L5 nerve roots. So then when I go to L4-5 to read what it says specifically, it says disc bulge with central annular fissure, which is just an irritation or injury of the annulus fibrosus. So the annulus fibrosus is the enveloping of the inner gel texture or structure within the disc. There are the layers of connective tissue rings, basically, that are a little bit harder in structure. So there's an injury to those annulus fibrosus fibers, which has resulted in a shallow, inferiorly migrating. So the disc is moving downwards. The component of the disc is moving downwards, and subsequently it's called a disc extrusion. So an 11 millimeter disc extrusion. So a disc extrusion is basically when there is a type of disc herniation where the contents of the disc have now moved downwards to irritate the nerves as they're traveling in your spine. And then it says there's moderate lateral recess narrowing, again, with impingement of the descending L5 nerve roots. And then it says no foraminal stenosis. So there's no narrowing in the tunnel where the nerves come out of as they're coming out, but there is narrowing just before they leave in that lateral recess. Stenosis means narrowing. And then if I look at the other levels, so T12L1, no disc herniation, central canal is the main tunnel where the spinal cord travels down and then eventually branches off or finishes, and then the nerves continue down as an extension. So no central canal or foraminal stenosis. So again, stenosis is narrowing, foramen are the tunnels where the nerves come out of. That's the same, written the same at T12L1, L1-2, L2-3, L3-4. So normal at those levels, and then L4-5 we mentioned, and then L5-S1, a little bit of change. So disc bulge with central annular fissure, same thing, and a disc protrusion. So a disc protrusion is a type of disc herniation as well, and slightly less severe than the disc herniation in terms of the amount of change in the integrity of the disc. So it goes disc protrusion, disc extrusion, and then disc sequestration, where a piece of the disc actually comes off from the rest of the disc. So disc protrusion is the least severe of the three, but regardless, there is a disc protrusion at L5-S1. Minimal thecal sac narrowing. So the thecal sac is basically the sleeve that the nerves are enveloped in as they continue to travel down from an extension from your spinal cord. So there's a little bit of narrowing in that region, and then no foraminal narrowing. So again, not really anything that we're concerned about specifically at that level. It's more so the L4-5 that we're looking at more in depth. And then under the findings, we look at conus. It says the conus is basically the end of your spinal cord. It usually ends at about the level of L1. It says it terminates in the normal position and it demonstrates normal signal characteristics, so that's good. That's reassuring. The cauda equina, it says unremarkable. So cauda equina is basically the nerve roots that continue to travel down from the spinal cord into your sacrum, and then these nerve roots are responsible for bowel and bladder function. And when these nerve roots become compressed, there's a condition called cauda equina syndrome, which is a medical emergency that would require immediate medical attention if you have the symptoms. So numbness when you pee or poo, peeing your pants, pooing your pants, lack of sensation, pain going down both legs, numbness going down both legs, and possibly progressive weakness in your legs as well. That would be a surgical emergency that needs to be dealt with ASAP. So this says that it's normal, so that's good. Osseous structures, osseous is bone, so bone structures, it says vertebral bodies are normal in height without fractures, so no fractures, that's good. Vertebral bodies are just the bones of your back. Alignment, it says there's a grade 1 retrolisthesis of L4 and L5. So a retrolisthesis is basically when there's some movement backwards of the L4 bone on the L5 bone, and they grade that as grade 1. So it's graded from 1 to 5 in terms of how much movement there is forward and back relative to the bone above and below. So grade 1 is the least severe of the 5 in terms of how much movement there is. It means 0 to 25% of the diameter of the bones from one end to the other, forward and back. But regardless, there is a bit of movement at that level at L4-5. That's something to be mindful of. Could be playing a role in some of the symptoms as well, but generally grade 1 isn't a significant amount of movement relatively. Of course, you'd have to see the photos to see if it's on the upper end of grade 1 or on the lower end, but regardless, it's what it says. A bone marrow, normal bone marrow signal, no focal, osseous, or bone lesion is seen, so that's good. Just looking at the health of the bone marrow. And then paraspinal soft tissue, so the bones, paraspinal soft tissues, the muscles, tendons, ligaments. Looking at the integrity, it says paraspinal soft tissues are remarkable. Disc desiccation, or just changes, wear and tear changes of the disc at L4-S1 levels, which we commented on before. Remaining discs are normal. So that's basically a summary of the MRI and kind of what some of those terms mean and what they're commenting on to hopefully give you a bit of an idea of what it looks like. The key thing though with these MRIs is they're just one piece of the overall puzzle for an individual's presentation. Sometimes people can have lots of findings on imaging and have no symptoms or very little symptoms, and sometimes people can have very little findings on imaging and have lots of symptoms. Imaging is just one key piece. We have to try to correlate the symptoms that you have versus what the MRI shows, see how strong the correlation is, and then determine what the best route is moving forward. So in this case, it says pain going down both legs. How long has it been? Has it been getting better, same, or worse? Where is it traveling down your legs? Do you have numbness as well? Do you have weakness? How far down does it travel? And what pathway, as I mentioned? Have you tried anything that has helped? Physio, pain medications, heat, ice, What's the percent recovery? Is it back dominant or leg dominant? Is it right or left more, or mainly left, mainly right? These are all the questions that we would also be asking in addition, and then we would do an examination as well to kind of see what you can do and what you can't. So looking at reflexes, strength testing, sensation, range of motion, can you walk on your heels and toes? Are there any other concerning findings to cause us to look at your mid-back or your neck? This would all be kind of done in a comprehensive way so that we can try to figure out basically what the best route is moving forward. Because if you have these findings on imaging, but you have very little leg pain, like it says that the individual has it in both legs, but very little relative to the back, and it's mainly in the back, that surgery doesn't generally help with primarily low back pain. It's generally more for the leg symptoms, like the dominant leg symptoms that haven't been getting better, and there's noticeable pathology on the imaging. So that's why it's important that we ask the right questions, get the information, do the examination, and then make the correlation with the MRI and the symptoms to see what the best route is moving forward. So there you have it. We went over this sample MRI that I just found off the internet for confidentiality purposes, as to not use any MRIs for any of my patients. Do you have back pain, neck pain, mid-back pain? Have you had an MRI done before? Did you have any questions about the MRI, or did you feel like the MRI wasn't really reviewed thoroughly with you and you don't really understand what it means? Well, let me know down in the comments below. I'd love to hear your story and kind of what your pathway has been, if you have any spine pain or leg or arm symptoms. And if you found value, please consider checking out some of my other videos. I have over 500 videos on various physio, exercise, and medical related topics. And if you still find value, please consider subscribing to my channel. It really allows my channel to grow and allows me to reach a wider audience. Until then, I'll see you in the next video. Thanks for watching.